And to your point, we grew up in a culture that did not think that our needs were worth meeting. And I kind of bought that too. I mean, I think I drank the Kool-Aid because we thought, well, we're in a healing profession and we're supposed to be altruistic. And that means always putting other people's needs above our own, which, in the moment, of course, yes, of course we do, right? Our patients
Yeah.
come first, right?
Yeah.
Or our families, for sure. But always, never, ever, ever processing our own emotions and also recognizing our own humanity, and that because we are human and because we're so committed and caring and compassionate, we are going to have suffering. We see suffering and things go wrong and there's lots of stressors. And really that this is something that we all need to think about, because we can't lose our workforce.
No.
That's not going to work for anybody. And so this is I hope I'm not overstating, but it does feel a little bit like an existential threat to the healthcare workforce if we aren't better about addressing these stressors.
Yeah.
I'm going to pause, but I did want to say something is I think, organizations also have to move on from this idea that we're supposed to solve the problem individually, that we should be dealing with this. Oh, yes, you should just, individual resilience, why don't you go and, why don't you go and do, go take a run or, meditate, et cetera. All these things are really good, these individual resilience training. But, well, what about the organization, first of all, providing actual support, like peer support, but also what about the organization stopping doing the things that are harming us, with this
Yeah.
increased production pressure and decreased resources? It's like there's only so much we can do without either burning out or also, giving unsafe care. And I
Right.
think organizations have to really wake up and say, we have responsibility for creating safe work environments that are safe for us as the providers of the care, but and therefore safe for patients. And that's really key. And I don't want anyone to take away thinking peer support is just like, hey, you all solve it yourself. It's like, no, no, no. This is, you said it's a collaborative effort,
Yeah.
and society probably too, has to be part of it. Is what can we do to work
Right.
towards improving this?
That's really interesting because I do think that pulling in administration, obviously, to get buy-in and just educating them about the importance of what peer support programs look like. Can you talk about a little bit for the audience what a peer support program looks like and how it should work? That might be a really nice, kind of segue into getting buy-in from administration.
I'd love to. So I think of support as a spectrum, right? There's lots of ways we can support healthcare providers. So one is that we've all had experience doing, which is informal support. You check in with somebody. Hey, how's it going? Heard you had a rough day yesterday, or gosh, it's been really stressful this past week. As you know, as an ICU nurse, sometimes you're just seeing really hard, really awful things.
Yeah.
Just patient outcomes because of the way diseases progress.
Yeah.
So informal peer support is wonderful, but it's not good enough in some situations, it's not enough for some people. It's not meant to, you're not really providing a way for someone to really unpack what's going on or if they're really traumatized. So it's good, but then there's what I call formal peer support, which is what I help organizations do, which is set up an actual program. So what makes this different? And that is the support, first of all, is done by a colleague, not a behavioral health person, right? So it could be a surgeon like I am. It could be, somebody's trained to
Yeah.
be able to do this. And it requires some training because it's not something we do. We're used to fixing people's problems. You bring me your
Right.
problem, I will fix it as a surgeon. But this is not fixing your colleague. It's helping them navigate these stressors and access their own ways of coping, et cetera, but helping them in a way that I think we can be trained to do. And so fair disclosure is I do the training, so
Yeah.
I'm an educator. I think education is really helpful. So that's formal peer support, and the other job of a peer supporter is to destigmatize and facilitate referral for further along on that spectrum, further support in the form of professional help, whether that be coaching or behavioral health, whatever it is, because some people, formal peer support will be enough, but others will need and want more. And yet, as we spoke about, there's barriers to accessing that. So what formal peer support does is it helps people, if they want that support, get it and get it easily. And that's really sort of a picture of what it is. Interestingly, if you look at lots of initiatives that are needed to support well-being, peer support it's not really costly. It's really not a big, expensive program. And there are certainly well-being programs that are expensive and need those resources, so that's all good. This is just not one of those. And we have data to show that it's something that people want. We have done some studies that said this is one of the factors that actually helps people with some of these workplace stressors. So, one of the ways of working with leaders in healthcare is to show them, one is the need, and there's so much need, and that there's so much data about the need, which is, I'll give you one example. If you take a specific stressor, like making a medical error that's harmed a patient, which is not the most frequent thing that happens to any of us, thank goodness, in our careers, but it does happen to
Does
pretty much
happen.
everybody. Yeah. Um, if you've made a medical error, and this happens to be a physician study, although I did also study with physicians and nurses, so just take that, it's not just about physicians. There is there's a significant emotional fallout from that,
Yeah.
including, and it's an independent predictor of both burnout and depression, having made a medical error.
Hmm.
In addition, we know from a good study that it's a risk factor for increased suicidal ideation.
It
So
is.
those are
Yeah.
pretty dramatic bad things that can happen.
Yeah.
And remembering that if you're burnt out, so there's a higher chance of becoming burnt out if you've made an error, you have a high, just being burnt out, period, you have a higher chance of making medical error. Plus, just being burned out, period, from whatever cause, is associated with a poorer patient care on lots of domains. So I think for leadership, for them to resource something, they should know what's the need, and the need is clear, right? And the data shows that. And then what's a program that is called for based on the data. And this is an example of a program. It's not the only program, it's a program. But I think, to be fair, leaders do have resource constraints. And so you can't just say, we want this, I
Right.
mean, I would like to be able to, trust me, but you have to provide data, if you will, of it, why it's necessary. So a lot of what I do is help organizations make the case to their leadership of, like, we got to do this as one program. I mean, it's not going to
Yeah.
solve all problems.
And figure out
So
how to
yeah.
fit it in.
Yeah, that's
Yeah.
right. And it's very doable. It's really not that complicated. The other unique thing, for those of you who are listening who haven't heard of this, about peer support, is that you want to make the support, if someone says, oh gosh, I'm suffering and I need help, it's got to be very easy for them to access this support, right? So they have to have a number to call. It's got to be easy, got to be confidential, etc. That's not enough. What you also need is, you need to proactively offer peer support to people who have been through an event, not whether they're stressed or not. You don't know them necessarily whether they're stressed, but instead of waiting for healthcare providers to exhibit signs of distress, we with peer support, they will get a call from a peer supporter saying, we heard there was an event, or we heard there's, this week was very tough, and I'm offering you peer support because we have this program, because I've been there and I know how hard it can be. And sometimes it's helpful to talk to a colleague. Would you like to do that? It is not forcing anybody. Nobody should ever be forced to get any support or talk about something they've been through. But see how easy I'm making it and destigmatizing it. Hey, I'm reaching out to you, not because you're a big loser, but because this is what we now do. Of course we reach out. We
Right.
wouldn't think of just letting you go and deal with this on your own, which is what we have done forever.
Yeah, it becomes just the standard response that we give. That's really interesting, because I was going to ask you, you brought up a really good point that, as nurses and physicians, and even in our personal lives, right, we want to fix everything. It's hard for us to be active listeners because we're always wanting to fix it. So I like that methodology that you're proactive based on an event in the hospital or what have you, that you're reaching out that helping hand, taking away that feeling that for a provider to just say, should I call, should I and you're just have that set up. Is there, do you work with hospitals to leverage technology in, I mean, how do you do it via email? Do they log into I mean, I guess it just depends on what the organization wants, right?
Yeah, no, I mean, I think probably, going forward, there probably are very creative ways to make this more, to expand these programs. But the way we've done it, for the past good decade and a half, uh, with all these other organizations is usually the reach out would be, let's if I were reaching out to you, I would email you, and in the subject line, I'd put touch base, and I'd say, "Hi, Adrian, I'm reaching out as a peer supporter. Please give me a call when you get a chance." So then you call me because I don't think explaining this on email is really going to do it. It's
Yeah.
too nuanced. So you
Yeah.
call me, and I say what I just said to you earlier, which is we have this. I don't know if you know this. We have a peer support program, etc. And so I'm destigmatizing it, and I'm just making it routine, and explaining it to you, verbally. And
Yeah.
then if you say, I say, would you like that? And if you say, you know what, I'm good, thanks anyway, I say, yeah, that's fine. Is it okay if I send you a list of other resources? So if for whatever reason you or any of your colleagues says, you know what, I'm kind of stressed about something, there are resources that you could have, and you can reach out to these people. Or if you'd like, you can tell me you'd like someone to reach out to you or a colleague. I can make that happen if that's what, if you'd prefer. Sure. Thank you so much, Joe. That sounds great. If they say, yes, I would like this, then you figure out a time of mutual convenience. And we have been using, you know, uh, visual remote technology like, this Teams or Zoom or what have you, for peer support for years. And before
Mhm.
that, we would do it by phone sometimes or in
Yeah.
person. It works any of those ways. So in that
Sure.
way, we're leveraging that technology. I think, there's I have been thinking that there should be also even better ways to spread the support. So I'm thinking about how to do that, but it does work pretty well. I think the biggest problem is how do you get how do the people who run the peer support program get notice that something has happened or that there's been, significant type of stress? And that can be a hard connection to build.
Yeah.
When I was at the Brigham, we had a really great relationship with patient safety and risk management who heard about some of these big events, and then also the leaders, the chiefs and the chairs who would be like, oh, there was a patient aggression or something, and there was
Right.
lots of word of mouth. So we would hear about a lot of things, but that takes a while to build those relationships. So
Yeah.
that's an area for improvement.
Yeah, creating a workflow. We're getting close to our time, and I tell you, I could talk to you about this all day long. And I really wish in listening to your conversation, I wish back in the early day, which I'm sure, looking back, you do too. I wish we had something like this for me. I mean, like you said, working, under the conditions that we did, without really having outlets or feeling comfortable or like it was okay to talk about the stress of what you were going through as a nurse or a physician. I mean, this is fabulous work. I just can't tell you how much I am impressed, and thank you for your time. And if people are interested in learning more about peer support, can they find you on LinkedIn?
Absolutely. Yes, for sure.
Okay. All right. Because I have a feeling that some people are going to want to connect with you. And I just want to thank you again for your time. And for the listeners, thank you for listening. A new dialogue with Risk and Patient Safety Leaders podcast. Again, if you found today's talk valuable, please share it and subscribe. And if you'd like to participate as a guest, as I mentioned earlier in the podcast, you can reach us at speakers@medplace.com. Thank you so much. And thank you, Dr. Shapiro.
Thank you for having me.